if a mother, well, I'm not going to do a mother because I'm going to do the mother later, about how you explain this to the mother. If a kid, because if you tell children, and okay, we're talking about kids with anxiety problems, anxious, nervous, scared, kids who maybe have been avoiding things for a long time, and you present the rationale that we're going to gradually ask you to face your fears and to gradually take small steps. Who remembers Abbott and Costello? The kids never remember Abbott and Costello. I don't know why. I don't know why the kids don't know Abbott and Costello. Slowly I take, and I do this with the kids. I go step by step, inch by inch. We're going to have you face the things that get you scared. What do you mean you're going to have me do that? How would somebody, knowing what is in store for you, would somebody like to explain it to the child, explain what I've explained to a child?
That you're very afraid of those eraser shavings every time your classmate rubs out her things with her eraser, and it's upsetting you, and you don't want to go to school because of it. Is that right? So we're going to practice in my office erasing a lot. Do you have any idea why I might have you do that? Because I know you don't like to do it. It grosses you out. But I bet the more you do it, the more used you're going to get to those eraser shavings, and you're going to feel a lot better about it.
Why?
Well, I've worked with other kids that have had similar things that they don't like to do or things that make them uncomfortable, and what I've found is the more I get them exposed or used to the things that they don't like, they might not love it, but at least they're more comfortable around it and they don't avoid it as much. And the avoiding it is causing you a lot of problems at school, right? So you think you could work with me to erase a lot, or try to erase a lot in here so we can get used to those little shavings?
I can try, but I don't know. It sounds really hard. It sounds really scary, and I don't know if I want to do that.
It probably will be scary at first, and you might feel uncomfortable when you do it, but I'm here, and I'm going to be here doing it with you, coaching you through it. And I think if you're willing to work with me, we can get you feeling more comfortable around those eraser stuff.
That's fine. That's good. I also, though, would recommend, first of all, drawing the curve. And it is in the workbook. Drawing the curve and say, look, initially it's going to be hard, and you're going to get really scared. But you know what? If you do it, it's going to go down. It's the fear curve. And you know what? What goes up, and it's in the manual, what goes up must come down. And this is going to come up, and it's going to go down. And that's a nice metaphor. What goes up must go down. Also, the bicycle metaphor the kids get. If you fall off a bicycle, what do you do when you fall off a bicycle? Get back on. It's really the same idea. This is like getting back on the bicycle. We know it's going to be hard, but we're going to do it slowly, step by step. And if you do this, and if you practice this, this is going to work. Another good thing to say to them. This works, but it depends on you doing it. Because when people say, I've tried it, it didn't work, it's like, parents who say, I've tried, I've tried reinforcement, it doesn't work. I mean, reinforcement works. I mean, it's just like if you don't do it applied correctly, it doesn't work. If you don't practice this, if you do things to, and we'll talk about things you can do not to make it not work. But if you practice it and do it, it's going to reduce your problem. The reason why it doesn't work, remember I said 20 to 40% of kids don't improve in these treatments? It's not because the treatment necessarily didn't work, it's because they weren't able, and maybe for different reasons, they weren't able to really get engaged in the treatment. They were too scared to try the treatment. There was they didn't really, the exposures weren't on the things that really were the core fears. So, that could be a lot of, you're not focusing on the right targets. But if you are focusing on it, it should work. But again, you don't have a 100% success rate. Okay, now, in terms of habituation experience, I said we don't know why exposure works. One reason is this habituation curve. It's a physiological thing. You stay there, and physiologically, it habituates. But there's other explanations, and this is exactly what you were saying about self-efficacy or resilience. And it is. The kids think, I can't do this. I can't stay in that situation. I can't be left alone without my mom. But then you do it, and then you say, okay, what happened? So what happened?
Nothing.
So how does that make you feel?
I'm not sure.
Mm-hmm.
I don't think I was, well, I guess I was scared, but then it stopped.
Mm-hmm. And so, did you learn anything from this? Like, what do you think? Like, what do you think about that?
I guess that nothing bad gonna happen. Nothing happened.
Mm-hmm.
That's bad.
Mm-hmm. Okay, so it gives them a feeling of self-efficacy or competency in coping. I mean, that's theoretically, that's one explanation. That's a more cognitive-mediated explanation. Is you do the exposure. The habituation is more like an emotional processing. You stay in there, but then over time, it goes down, the habituation. Another thing is more cognitive. You do it, and then it mediates cognitive changes where you say, oh, the worst didn't happen. Oh, I can handle it after all. I am brave. It's not so bad. I'm strong. That's a coping. Or I'm actually pretty good after all. So that's another explanation. And another reason why people think exposure can work is because, and this is why I like to do exposure first and then do the cognitive, is because I can then make the cognitive restructuring more relevant. Because instead of speaking in the abstract, instead of speaking in the abstract, so what do you think will happen? Let's talk about it. We actually do it. And then immediately after we do it, we process it together. And processing is very important. You do the exposures, but you don't just do it. You don't just do it. You do it, and then you need time in the session to process it. Process it meaning, so what happened? What did you think was going to happen? What did you learn? Okay? Okay, this one I didn't remember yesterday. This one's good too. Treating batters who are afraid of the ball. That's very good, Bill. Go ahead, touch the ball. The ball is our friend. So this is exposure, and this is cognitive restructuring. This is an example of cognitive restructuring in the moment, really, making the cognitive restructuring relevant. And here's another example. Hey, don't be scared, Joey. Thunder is just a loud cloud. Okay, again, it's exposure, and it's a cognitive restructuring. Right, isn't it? And I forgot this one yesterday, too, during my talk. Okay, all right. But, yes?
Do you do all the exposures in the office?
No, we do not do all the exposures in the office. We all over the campus. I mean, sometimes we do it in the office, and we're gonna spend more time going exposure and giving you more examples right now. So let's save that, okay? They're all over. Yeah.
So like if it's frogs, you'll find a way for them to be with frogs.
We have frogs on campus. We have the.
And needles.
Yeah. And we bring a lot of. We bring them to this. We go to the health clinic on campus, and we also have them. We call the pediatricians' offices, and we make arrangements with the pediatrician offices to have them be able to go to the pediatrician office and do things like that.
You don't have them do more and more needles. You just have them supposed to be around them.
Yeah, but if we can work with the pediatrician and the nurses, they are able to do things, in a gradual way relating to the syringes and the needles. But no, we don't shoot up the kids. Yeah, I mean, yeah.
No, but I mean, even at the office, they don't have a series of those saline shots. So they get used
No, we don't do that. I don't do that. I wouldn't feel comfortable doing that. But we do, you know, I'm not allowed to have that stuff at FIU in my office, but we go to the health center, and then we call the pediatricians. And, you know, we do get a lot of, when I say collaboration, we collaborate with the teachers. And some of you, you know, I've called some of you, right? And I've worked with some of you, yeah. You know, and I work with you, and we work out things with the counselors and the teachers and pediatricians, and, you know, we do what we can.
Maybe not in the office, but you do.
We do as much as we can in the office, but if things are not, but then we do in-session exposures and out of session. And at the end of every meeting, it's making a plan for the next exposure. Oh, that's a good question. Okay, all right, okay. So this is just some possible, okay? But so some possible targets would be dogs in different contexts, social situations such as speaking in groups, separation situations, and GAD, exposing child to situations that will provide incompatible information with worries. Tell us about your friend. Let me tell you about my other friend.
So my brother?
This is my brother. Okay, let me tell you about my brother.
Yeah.
Okay.
So you may get to this, and I don't want to open a whole other can of worms, but
Worms. Okay.
So I have this can. In terms of exposing in schools, doing exposures for school, we see a lot of social anxiety and things like that. Do you still recommend doing exposures in school?
Oh, totally.
And then my second question on that then would be, what happens if there's traumatization that happens during an exposure? And you can't control the situation if it's a social anxiety getting up in front of a classroom or all those different things. And what happens if they're not being supported in those experiences?
Okay, that's a really great question. And in fact, yesterday when John Lockman had his slide of myths, I was thinking, boy, I used to have a slide of myths. I wish I had my slide of myths because I don't have my slide of myths because, this thing, I've been doing this for a long time and I have to change it otherwise. So there is that idea that if you do exposures, people are going to get traumatized or they're going to have psychotic breakdowns. People and some people think that. It does mean, though, when you do these exposures, you don't want to do something that's stupid. Stupid meaning so little anxiety is provoked, it's a waste of time. But you also don't want to do something so much that it's like a flooding. So that's why, and we'll see, we're going to practice tomorrow role-playing and setting up hierarchies and how you do that. It has to be at the level of what the child feels comfortable at. And you don't want to elicit, the curve? You don't want to elicit too much, that they're freaking out. And because you know why? They'll never come back to you. They'll never come back. And we have lost, when I say it doesn't work, people drop out. Why do people drop out? Because it was maybe too much, too fast. They couldn't handle it. It was too scary. And they might say all this stuff, like why they're not coming back. But many times it's because it's too scary and they don't want to do it. And when our previous grant was running group treatment versus family treatment, and we randomly assigned people to group and family. So what happens when you tell a mother with a child with social anxiety? With social anxiety, your child's been randomized to the group treatment, and the mother calls back and says, my child doesn't want to be in the group, can she be in the family? And so what do you think I say? Knowing me now that you know me for these hours, what do you think I say? I say, well, yes? What do you think I say when they say, my child doesn't want to be in the group because, she got really scared. She was really hoping that she'd be assigned, when you flip the coin. So what do you think I say? I say, well, that's why she needs to be in the group. And, I've learned, even though it might seem like I'm yappity-yappy, when I'm speaking with the parents and the kids, I say as little as possible. I've learned to say things in really short, concise bullet points. That's why she needs to be in the group. What do you mean that's why? That's why she needs to be in the group. What do you mean? We learn to face our fears in this program. I try to keep it really like bullet points so that they can get the main points, because I feel if you say too much, they get confused and that you lose them. And the fact is, That's why she needs to be in the group. And then what we then do, I mean, I'm getting off on tangents, but what we then do to get them in the group, we say, well, look, they don't have to come to the group, sit in the group the first day. Just get her to come just get her to come to campus. Then that becomes an exposure. Get her at least drive to campus, or come to the waiting room, or and then they only have to sit there for 2 minutes or 5 minutes. That becomes the exposure. And I'm not going to lie to you. Depending on the severity of the cases, you're not always going to make 100% success. But everything is step by step. And that's what it is. I mean, I'm not going to lie and tell you that we have immediate success. And I do think the timing issue is important. Like, somebody asked me about timing, and I don't know. I really have to look into this, whether or not the drugs work faster. I really don't know. I don't know the answer. If you looked at my slides from yesterday, I skipped it because of the time. But yesterday I had a slide under timing. And one of the things we're doing in our current research is we're trying to get at that question of timing. You know what I'm saying? We're going to, because we're measuring everything, so we're going to look to see, when does change occur and when does it predict outcome. So we're going to be measuring, because we're measuring these things, is it in the beginning for some people that they learn everything and then they're cool? Or is it more at the end that they learn everything and then they're cool? Or is it more like a gradual process that they learn things and then they're cool? And our research study is actually also designed to get at the question of timing. Now, what would really be cool is to do another study where you compare it to drugs, and assess timing with CBT versus drugs. But anyway, did I answer your question? Okay. Yeah.
Her question made me think of a question. So I was just wondering where, if at all, you sequence relaxation training, because usually what I do when that happens, because I've taught them relaxation strategies, then in the moment, we start doing the relaxation strategies to try to help them regulate that emotion.
This is just me, okay, and this is not, well, it's just my own personal thing. So we have some slides with relaxation. I don't always do relaxation because it sometimes can block the experience of the anxiety, and you want them to experience the anxiety during an exposure. So there is something theoretically to be said. However, I don't misinterpret me that relaxation is good, but it may not necessarily be useful to be used in conjunction with exposure. So you have to figure out other times when relaxation is a good thing to do. Like, maybe like in the classroom, they can't necessarily do an exposure, and that's when they can maybe practice their relaxation skills. But does that make sense? Yeah. So relaxation is not a major component of the treatment of, and in fact, in the adult anxiety area, relaxation has been used as a control condition. It's a placebo, and it hasn't been found to work compared to CBT. And that's the reason. Because you don't want to you don't want people to be distracting themselves when they're doing these tasks. You want them to get anxious.
Yeah, I was just going to say, in some of our work with treating kids, a big take-home message that we try to tell them is that you might be feeling a lot of anxiety, but does that actually do anything to you? Do those feelings actually harm you? And so the idea is to really get them to feel it a lot so that they know, like, okay, it's very uncomfortable, but it doesn't hurt me, and it will eventually go down and go away.
Yeah, no, I think that's really good. I think it's really good to explain to the children, what does anxiety not let me do? Why would my life be better if I didn't have this anxiety? And that's a motivator. But I do want to make it very clear that, because again, I'm always afraid I'm taking away the wrong message. Relaxation is part of treatments, but you need to use it in a way that's judicious. And like, for example, if and not having the kids during exposure. But, sometimes you have to think what the problem is. If some kids have a lot of physical tension, then the relaxation can be helpful, like when they're lying in bed at night. They're not going to go out and do exposures, So that's where it could be helpful. And I have some slides later about how to do relaxation. Okay, now GAD. So this is actually interesting. So for example, GAD, as I said, is the most complicated of how to come up with exposures. But there's a lot of things you can do. Like the internet is a valuable source. I mean, a lot of times you get information, so getting information incompatible is sort of an exposure. So a lot of times if kids are worrying about lots of different things, we might go on the internet and do some research about, whatever it is that they're worrying about. If they're really worried about hurricanes and what's happening with hurricanes, or if they're really worried, let's use that example. And when we talk with them about hurricanes can be really terrible, but we also talk to them about the preparation involved with hurricanes, how we usually have an advanced warning, and how we can make ourselves safer from hurricanes. And even though hurricanes are likely, look at how many, terrible ones, as terrible as they've been, they haven't occurred that frequently. That's an example of incompatible. It's just providing some information. If they're worried, a big thing with the GAD kids is burglaries and robberies and personal safety and harm. And another thing that we do is we go around, we have them take a clipboard and we have them go and take a survey to people around campus, and we ask them, how many times, and believe it or not, even in Miami, it works. Thank God. We say to them, we ask them, and we usually do it set up like around the clinic and the center, but we have the child say, can I ask you a question? And they come to my office, Dr. Silverman, can I ask you a question? I go, yeah. Have you been robbed in the past year since living in down here? No. Have you ever been robbed living here? No. And then they knock on, ask some other students or graduate students, have you been robbed since you've been here? No. And be honest, tell me the truth. Have you been? Okay, be truthful. Okay, well, okay. So she's been robbed. Okay, but we get that information. And have you been? Okay, have you? Okay, and how many times? Twice. Okay, and you, Mr. Silverman? No. Buffalo, no. That's what. Once. Well, okay, no, and okay, in the past year. And you? And you? And you? Huh? You're a cop. Okay, well, that's good. That's good. Okay, but I'm telling you that. But that's what we do. That's what we do, and then we come back to the office and we say, okay, you talk to. Now we're going to do a little math. How's your math? Oh, I hate math. Okay, well, I'm going to help you do some math. I hate math too, but maybe with the calculator we can figure this out. So we talk to 10, no, let's say 20 people. 10, 20. Let's say 10, because I know the math gets too hard otherwise. We did 10 people. We talked to 2 people out of 10 said yes. So what's 2 out of 10? 20%. What do you think? Okay, let's do it again. Let's do it again. And if you do it 3, 4, 5 times, believe it or not, we've done this enough. You'd be surprised, you guys, all of us who live in Miami. Usually it's 0 to 1 person. Really, I know we all think we live in this terrible crime-ridden place, but in fact, when you ask the people, and again, that's just a way of exposing. It's a good one, right? Yeah, that's a good one, because another thing is you can go on the internet and get the statistics. That's another thing. But this is where you need to be creative in GAD. You need to come up with, well, what is it? And then like if it's traffic accidents, even with the phobias, you can do this type of thing in providing incompatible information. So and I do believe this is what I was saying, the core fear. And that's what I was saying before, because I do believe that you need to be a good conceptualizer and an assessor. You need to conceptualize things. There's a famous story that I remember learning when I was in graduate school. And this is when systematic desensitization was like the hot thing, which is really the same thing. It's gradual exposure, but it's more an imagination, and you pair it with relaxation. It was developed by Joseph Wolpe. WOLPE. This is just, it's all, everything is, based on everything. And, when he was doing systematic desensitization, I remember reading in a textbook about a man who had a phobia of bridges. You know this famous case? And they treated him for exposure of the bridges. But he still had the phobia of bridges, right? Does anybody want to, I think this one's deserving of a ball. Does anybody want to take a guess why you did the exposure of the bridges, but he was not cured? And this is, well, and I'm already giving you a hint. Okay, well, this is good. Sorry, guys. You'll get one eventually. You'll get one eventually. Don't worry.
Maybe I'll share. Maybe I'll share my ball with you if I win. Maybe he was really afraid of heights.
But why? Okay, that's good. Height is good.
Maybe it was like something more broad.
No,
different.
Yeah. So you. That wasn't the one I had in my head. But you're right. You thought it was the fear of bridges, going over, but it was really the heights. And what do you say? Should I give it to her? Yeah. Okay. I mean, basically what you're saying is that you need to get at the specifics of the bridge. And that's really, really true. You need to get at the specifics. What is it about the bridge? Is it going across? Is it the height? Is it going up? And that's really one important point. So what you guys really talked about is you need to, and we're going to practice this tomorrow, you really need to get at the details and the specifics of the situations and do that. Because if you're focusing on, and I've learned this from mistakes, like that, we might say, oh, just get them to cross the bridge. It's like, no, and then you learn after session 7, they did it. Well, I thought it's not that, it's the going up, as you said. So that's one thing. And sometimes it's the going across and the heights, and then you have to manipulate both. So these are both examples, and and I'm going to give you the ball.
You can have it.
Because I think they're good examples. But I was thinking of something else about.
I can do ball exposure.
Okay. But does anybody? And then I'm only going to give a ball now if they have the answer that I'm looking for. Okay. Okay. No, because now. Okay. Okay. But. He thought he was going to jump off. Okay, you're getting, all right, so that's a good example. He thought he was going to jump off. In the book, that what they're saying is that what he was really afraid of, he was afraid of the boss. He was afraid of going across and going to work every day, because going across the bridge meant going to work and seeing this boss, and the boss was confronting, and he couldn't confront the boss. And the whole time, they give this example of you treating the phobia of the bridge. And this is why when people say exposure, CBT, it's simplistic, it's superficial, you know what? It is if you're going to jump like a jerk and the first thing they tell you, bridge, oh, let's do the bridge. You need to say, tell me about the bridge. What is it about the bridge? Is it about the height? Is it about going up? Is it about you're going to, you worry that you have thoughts about maybe not wanting to go all the way to the end? What happens when you go to the other side of the bridge? Who's there? What's there? This is conceptualizing treatment cases. This is not in any manuals. And when I told you we do these telephone calls every other week with the Reach Institute with people who we train. Like now we're doing it with a group in Texas. And I do believe that the main problem that the new people have when they do this is that they're too quick to start doing things and they haven't conceptualized. And they're too quick to say, okay, I started doing exposures of X. And then I say, well, what evidence do you have? I talk to you as a cognitive. What evidence do you have that that's what it should be? And they go, well, because they said they can't go on the bridge. And they go, well, but and then I would say to you, I would talk to you like you're like a cognitive therapist. Well, what is it about the bridge that's hard for them? Well, I don't know. They said it's the bridge. And then I say, well, there could be other things. And you need to go back and ask the child and the parent, more specifics. And this is, oops, jumped. And this is what people mean by the core fear, or the, I like to, some people call it the core, some people call it the themes, some people call it the cognitive schemas. There's different terms that people use. What are the schemas? What are the images? What are the core? And I'm telling you, a really, really good person doing this kind of therapy understands that. And when I work with my students, that's what I spend a lot of time with. The diagnosis gives you a working framework. Okay? It's a phobia, it's separation anxiety, but then what is it? Like with social anxiety, well, you say that they don't want to talk in front of people. You could just start doing an exposure of talking in front of other people. But what else conceptually can it be? Where's my mic? So if someone says to you, and we're going to practice this more tomorrow, but if someone says to you, I have, social anxiety, and they go, I can't talk in front of other people. Yeah, you can start tomorrow doing exposures, talking in front of other people, and maybe fine. But conceptualizing, what kind of questions would you ask in the first couple of meetings to try to get a little bit more about that?
What I wanted to bring out, because you brought the point about the bridge, in an eating disorder situation, there's that simplistic response that it is the model syndrome. I gotta look as good as. And in actuality, in this particular kid situation, with a lot more detailed questioning, it was not the model and I want to look as good as, who's out there, who's the most recent in the swimsuit. She wanted to disappear. In other words, we're going back to the social anxiety and being in a feeling that everybody is looking at me and what are they thinking, and I'm not measuring up, and I really just want to disappear in this room, and if I can get smaller, you won't see me. So the treatment, in other words, when we're not addressing that, the eating disorder was a manifestation of a lot of that anxiety.
Right. So what kind of exposure would you do? Did you do any exposure-based stuff?
We worked a lot about the negative thoughts, how she went on to the negative thoughts and she took one thing and it became very dysfunctional. We did try a little bit of exposure with one therapist who worked with a lot of OCD. Mm-hmm. But she was very, very resistant. She did not like the idea that he would walk up right behind her and say, oh, gee, do you have enough space to get through that hall? That was rattling. That was not something that she could handle. So, exposure was difficult.
Yeah, I mean, again, there's no doubt that, people are resistant to exposure, and that's why you have to explain it and do it gradually. And yeah, and if it's going to, and if you're going to make it if you're not going to explain it, and if you're just going to do it, you have to get permission from them to do things, and they have to know. And I've got another slide on that. But anyway, but before we can go on other slides, can somebody tell me more examples of, like, I'm afraid of speaking in front of a group? What else could be my core fear? Because you're not going to just do an exposure on the first thing they tell you. They say, it's hard, okay, so it's hard for you to speak. I don't want to do it. You do it for me. You tell me. You have an answer?
I have an idea.
Okay, yeah, an idea. No, an idea is fine. I don't mean an answer.
Maybe they don't feel they're prepared on the subject.
Okay, yeah. So one thing is that they're not, it's not so much about speaking in front of people, it's the fear that they're not prepared, which means then that what you need to do is you need to ensure that they're doing enough preparation. And that would be more what you'd be assigning them to do, is preparing. And it might be more important to have assignments where they're taught to prepare and how to prepare than just speaking in front of a group. That's a good example. Does anybody have another example?
It could be that they're afraid that they'll start blushing, or they'll start showing, they'll start sweating, and they don't want people to to see that, because then they'll.
Yeah, blushing. That's a good one. Blushing. It's not. I'm afraid about speaking in front of people. I'm just worried about the blushing. And then you say, okay, well then we need to come up with all the different types of situations where you are more likely to blush, and we got to get you into situations when you're blushing, because you know what? It's really not so much about speaking in front of the people. It's about the blushing. So what that means is that you can't, just because a mother or a child is telling you they can't talk in front of a group, they can't go across the bridge, you can't take it at face value. That's why CBT, if it doesn't work, it has to do with competency of the therapist. I don't know how else to say it. That you're too quick to jump into a conclusion. Oh, then let's do that. When it could be many different things that it could be, and your job is to explore it. What it says, need to conduct a thorough assessment. It's better for you to spend 2 sessions doing a thorough assessment and getting a handle on it than jumping into an exposure that's not going to work, because then they're saying, I don't know, that wasn't what it was, And then of course, and good clinical practice. I think it's like hypothesis testing. You have hypotheses, so you have a hypothesis that it's more. That it's this.
Well, another reason would be because I'm sure everybody will hate me and I'll get all the information wrong.
Yeah, I'll get all the information wrong.
I'll get it all wrong.
I'll get it all wrong.
I can't stand up there.
Exactly. I'll get it all wrong.
Yeah,
so the fear is not about speaking in front of the group. It has to do with making a mistake. And then you ask, well, is it that you're afraid about making a mistake, or you're afraid that they may think you're making a mistake? Do you see how it's complicated? I'm telling you, it's complicated. It's complicated that you have to really think of all the possibilities. It's like variables. There's lots of different variables. It could be this, it could be that, and you need to explore it. And then a lot of times I would say to the child, well, what is it that's really hard for you in terms of speaking in front of a group? Is it that you're worried that you're not prepared? Or is it that you're worried that you may make a mistake? Or that you're worried that people may think you're making a mistake? And then they might say, all of them. And then I say, okay, well then let's write this down, because that's going to be then part of our hierarchy. And we're going to do all of those things. Or it might be just one of those things, and you'll do that. So that's why, and this is, we're going to, this is all part of making the hierarchy. And we're going to spend some time tomorrow making hierarchies, because, these are the kinds of probing questions you need to ask. If you go to a phobia with dogs, a lot of times with we've treated a dog phobia, and we were treating this dog, and usually we're successful with the dog phobias, although sometimes they're pretty treatment resistant. You'd be surprised, because I remember with this one kid, he just was still really, really scared, and it turned out it wasn't really the dog per se. It was more just he didn't like the licking. It was just the licking, and the fear of the licking. So it wasn't enough just to have him face the dog and pet the dog or walk the dog. He really had to be licked, and then he had to have that licking stay on his arm without washing it off for an amount of time that was agreed upon, because he just didn't like that thing. And whether he thought, and sometimes that sometimes it's just a disgust, and you treat disgust. It's a disgust. You treat the disgust the same way as you treat a phobia. As a, it's exposure, and you just do it. It's just another.
Well, that's why I'm like sitting here and going.
And it is really disgusting.
Do I have to set the rat trap?
But we all think things are disgusting, but we're not going to expose. We're not going to avoid all disgusting things. We treat a lot of kids with the fear of vomiting. Very common. A lot. Now, the question to that is a few things. One question is this in a young child really a panic disorder? And that's one of the symptoms of the panic, it's sort of like panic attacks. And I do want to let you know that everything we're talking about is true for treating panic disorder. I mean, there isn't any different treatment for panic disorder. It's still exposure and CBT. So I just sort of, make that point. So with vomiting, it could be that it's really cued by, it's part of just the whole panicky feelings. So sometimes it is like a symptom of panic. So, the question is to explore if they have other symptoms of panic. palpitations, palpitations, thinking that, well, I don't want to go any further than that. But then what we usually ask is, what is it about panicking that makes you scared? What is it about panicking that, so what did I say, panicking? What is it about vomiting that you think might happen? What do you think? Okay, one hypothesis is if I vomit in public, I will be embarrassed. That's one hypothesis. What's the second hypothesis? If I vomit, I'm going to choke.
It's a loss.
And I'm going to die. Okay, if I vomit, I'm going to lose control. And I actually find that the choking is a big one. That a lot of times they're afraid of the choking. And, and then sometimes what we usually see, what's more common, I don't know, with your friend, does it affect her eating? Because what we see with the kids is that many of the kids, it's affecting their eating. When they're coming to us, it's not because the parents know that the child is afraid of vomiting. What the parents are noticing is that the child is eating in a weird way. So the child is only eating liquids. The child's only eating liquids, or the child's eating only certain types of foods because they've developed some idea that certain foods are not going to make them vomit and some will. So what we find out is, find out about the eating, and then we find out, okay, what is it about the eating and not eating? What foods can you eat? What foods do you not eat? And then what is it about the eating that you're scared about? And sometimes they'll say it's the choking, but sometimes they'll say it's the vomiting. So I'm just saying it could be different things. And then what we do, it's easy then to do exposure if it's to eating, because what we do, we bring to the clinic food. And we have, my students sometimes don't like this. They think they're going to gain weight because, we buy food with the kids, and the students are eating with the kid, the food. And it's an exposure. Like, okay, you think, and you do it gradual. Like, okay, you can break it up into morsels, but let's enlarge the size of the food. It could be the size of the food, or it could be the type of food. And it could be, well, you're only eating liquids now, or you're only eating baby food now. Let's try to go to, rice pudding. I mean, it's a hierarchy. And then you eat maybe something like a half of a French fry. And you do an exposure. And they didn't choke, and they didn't vomit. Vomiting, they can expose themselves. You can, like a lot of times you can elicit a feeling like they're going to vomit. Well, what do you think makes you vomit? Well, I'm afraid if I turn around. Well, then you have them turn around in the clinic.
For the embarrassment of.
And then you do it in front of a group of people. I'm telling you, that's what we do. Now, I mean, this is behavior therapy. You can talk and talk and talk, but this is doing things, and having them face the things, but that's where you need to, and we do a lot of that kind of creative stuff. We might have them turn around, or we might have them eat things. They might have to do it with a group of people, and then stay for as long as you think you need to show that they didn't vomit. So now let's get a little bit more about conducting exposures. First, some people say before you begin, get a rating. This is a fear thermometer, the 0 to 8 scale. Okay, how do you feel before you're doing this? Next, expose at the highest level the child agrees on for that session, or if you're doing assignments. So, you don't, and tomorrow we're going to practice creating hierarchies. So we're assuming you've done the hierarchies already. Right now I'm focusing more on how to do the exposure, but we're assuming you already have the hierarchy. So, but creating the hierarchy depends on having the core fear. So so you have the core fear, and then you're going to make a hierarchy. And now we're ready to do exposures. Then what do you expose them to? Again, time is precious. And in my opinion, you want to get the most bang for your buck. It's sort of like if you are coming from a psychoanalytic or a psychodynamic perspective, for some of you who do, there's the value of an interpretation. Remember the psychological, you make an interpretation that's, and you want to get at the right interpretation because that's going to like open up the insight for the person. And if you make the wrong interpretation, you just kind of, they look at you like, what are you saying? And the same is true for exposure. You want to do the most effective exposure. So if you're dealing, let's just talk about a dog because it's easy. You may not want to do looking at magazine pictures of dogs, even though that might be on your hierarchy. You might want to start out with, again, whatever they can do, the hardest thing first, so you can move up more quickly. And then during each time they're doing it, it's good to get them to rate. Okay, how do you feel now? And then you might want to keep, track every 10 minutes, 5 minutes. You have to see, and part of this is also agreeing how long. Sometimes you agree to stay. You say to them, "I want you to stay for as long as you possibly can." But then you might want to make a deal with them. Well, what's the longest you're willing to stay? And they might say, "I'm not doing it at all." Okay, well then we have to do the easier thing on the hierarchy. But then they say, "Okay, I'm ready to do." I'm ready to at least go. I'm ready to go from here to there to the dog. Or I'm ready to let my mom leave FIU and leave the clinic for 5 minutes. I'm just trying. I'm ready to ask a person one question. So these are the kinds of tasks you might have them do, and then if you can, you get them to rate their fears. Sometimes you can get ratings during the exposure, sometimes you can't, because if all they have to do is ask a question, then all you can do is, okay, how do you feel now? Rate it, and how do you feel after? And then, it's that fear curve. For some situations, trying to stay there as long as possible. All right. And see, do not allow coping or distraction or relaxation. This is sort of like, the people who do hardcore exposures, that's sort of their principles that guide them. Now again, there's flexibility with fidelity. So I don't want you all to think that this is rigid and carved in stone, because I'd be lying to you, because the research, we don't really know what makes anything work. But certainly, it's better to try to do, it's certainly a guiding principle to try to do something along these lines, And then you repeat it until they can handle it. And sometimes you have to do the same thing on the hierarchy, on the fear ladder. Maybe you have to go down. They never were able to do it. Or sometimes you say, okay, you did it, but your rating was, you never really went, you want to try to get down to you might say to the child on the 0 to 8 scale, right now you're rating it this is a 6. What do you want to try to get down to? What are you willing to live with? And they might say, well, I would like to be like a 2. And then you might need to spend a few sessions to get to a 2. And maybe they just never really got to 2. And you say, you know what, maybe we need to try something easier. And then try it again. So, and then only when they've moved on, they've done that, should you move on to something else. If that thing is important to do. Does that make sense? If that thing is important to do, you don't want to waste your time, and I'm going to spend more time. But you want to do what's important, what's interfering. So that's why I say everything that you're asking them to do should be something that's interfering. And if the child can do these things, if they could face the fears, they'll feel better. And we're going to talk more about that tomorrow.
What's interesting is there's some similar ways that you deal with the fears, the way you do motivational interviewing with substance abuse treatment when you're dealing with the resistance. It's so much the same language that you're using.
Yeah. No, I agree with you. It's like, well, there's everything. I mean, even yesterday when John Lockman, I thought that was so interesting when he talked about the arousal and the aggression and how they expose the aggressive kids to those situations so they can get in touch with the arousal that they experience when they're feeling aggressive. I mean, same, yeah. I mean, a lot of people think that exposure is a key therapeutic principle of all psychotherapy. You know, I mean, if you look at theories of therapy, I mean, like, you know, even psychodynamic therapy or play therapy or art therapy, it's doing some kind of exposure to things and having people learn that the things they thought was, you know, causing them trouble isn't really so bad. You know, so exposure is, you know, not just to anxiety reduction. It's one of the it's a theory of a lot of psychotherapy and change in general. You know, I mean,
to the core issue, it's
yeah.
the same thing. If
Yeah.
you don't know what you're treating, you miss the boat with whatever.
Right. I'm going to skip the slide right now. I don't want to do the slide because I'd rather we focus more on in vivo before we do imaginal. But I also wanted to say this because parents say to you, and it's the parents, they're going to say to you, oh, I do this. I make my kid do things. I tried that. You know, I tried. And then you need to say to them, well, this is the difference between what we do and what you do. What we're going to do is we're going to do it in a planned way. We're going to be very planful and careful and systematic. And it's going to be graded, you know, gradual. And it's going to be controlled. And it's going to be as long as they can, and it's a teamwork. This is very different, Mrs. Smith, Mrs. Garcia. This is very different than what happens day to day with Michael. Michael, you know, a lot of times when he's afraid about being away from you, it's because, you know, he doesn't know sometimes when you're leaving. Sometimes you're just late for picking him up, and he doesn't know. And he doesn't know in advance. And sometimes you leave him, you know, sometimes you've been as late as 1 hour to pick him up. And it's really, you know, like a big thing. It's not a little amount of time. And he doesn't know it's going to happen, so he feels, you know, he doesn't know how to handle it. And, well, the very brief isn't a good example here, but, you know, very brief can be, well, they saw the dog for a moment, you know, with the example I was using. And a lot of times, he's, you know, Michael's all alone and waiting for you. And that's very different than what we're going to do, where we're going to ask you to be away from Michael, but it's going to be very planned, and he's going to know when you're going to be away and how long, and we're going to maybe start off with 30 minutes, and then maybe we'll do, you know, an hour, and then maybe we'll even eventually get you and your husband to go out on Saturday night to see a movie. What do you think about that? Oh, wow, really? I haven't seen a movie since Gone with the Wind. Really? Wow. Okay. And we're going to make it happen for as long as possible, and we're going to do it all together. That's the difference between the exposure sessions that we're going to be doing here versus, you know, what happens day to day with your child. This is much more organized. Now, this is why sometimes people, look, I believe if you can get, I don't want to get myself out of business, but I don't really have a business, I just have a research program. I don't want to get myself out of my research program. I do believe that many parents can do this on their own, and they don't need the professional help. I mean, if people can gradually do these things, but you know what? Usually they can't. When it gets so bad, they need the systematic training in how to do this. You know, but I'm just making the point that, you know, it's not that it's complicated, but the principles are not that complicated. Yeah.
Can you give us an example of what it would look like for a social phobia or an adolescent that's afraid of what other people are thinking as they're walking down the hall?
Yeah. Yeah, I think because we're running out of time, we're going to practice these tomorrow. So is that okay? I'd rather just finish the conceptual differences. You know, so again, because we're getting too close to the end, doing effective exposure, the teamwork, and the other thing that you need to explain to them, and look, I know this is hard for you. I know asking you to be, having your mom leave you and being away from her makes you really scared. I understand that. But I promise you, we will never do anything that you don't know about in advance. When you come here week to week, you'll know in advance what it is we're going to do and practice. During the week, you'll know, we'll agree together on what you need to do. And I'll never surprise you with anything. And if you need me to show you, I'll show you some things. So what do you think about that? So does that make you feel a little bit better? Because I know it can be really scary thinking about your mom leaving. Okay. Do you have any questions about that? How do you do it in hierarchy for social anxiety? No. Okay. Okay. No. All right. And we're not doing this to make you really anxious. We're doing this because you're going to learn to manage your anxiety by doing it in this graded way. But I just told you what I'm going to do. But this is what I would like you to try really hard to do. To try to stay there as long as you can. Because remember I showed you that curve? And if the longer you stay, the fear and anxiety will go down. So are you willing to try that? Okay? And that's what we said before. I mean, and these are sort of the principles of doing the effective exposures. And as I say, the exposures are set up, and here's set up as a series of tests or experiments. Try this, and then we talk about it. Try this and talk about it. And then we already talked about the cognitive restructuring.